To talk about the history of neurointervention in India in 1 hour is a rather daunting task, and I don't know how much justice I will do, or even less than that time. Let's see how it goes. But I will not have too many images like I usually do for my talks. I will not give a technical talk because this is basically about history, and this history dates back to the 70s. So these are the two hospitals where I did most of my work. The KM Hospital on the left. This is in Mumbai, the GS Medical College and the KM Hospital. And the one on the right is where we are working now. That's the Bridge Candy Hospital. Um, to try and find out before we start on neurointervention, I thought let me also talk a little about neuroradiology before CT. Most of the audience must be post CT and post MR era, and you'll have no idea of what we did then before the CT. So I tried to find out who was the first one who did neuroradiology in India. So Professor Rao told me that Professor Mahadevan Pillai was the first radiologist to start neuroradiology in India, and this was at the Madras Medical College in Chennai, in Madras, then, with Professor Ramurthy. He was very innovative. He had trained in England with J.D. Bull, and he had started neuroradiology. And later, Professor Pillai moved to NIMHANS, and in fact started the Department of Neuroradiology in NIMHANS, and then also the Sri Chitra. Our generation of neurosurgeons, all of them, all across India, did our own neuroradiology. And this was some neurologists are also doing doing radiology, especially direct carotid puncture. But ventriculography, pneumography, myelography, and something called autotomography was being done by neurosurgeons. So what did it involve? In those days, there was no CT, there was no MR. So we had to make a clinical diagnosis. Is it supratentorial? Is it infratentorial? If it was supratentorial, we did an angiogram. If it was infratentorial, we usually did a ventriculogram. And angiogram was percutaneous puncture in the carotid in the neck. And the ventriculogram was through a borehole. So for instance, if there is a posterior fossa surgery in the posted for the day, we used to start in the morning at 7:30 with a borehole, usually posterior parietal, puncture the ventricle, inject either air. In the earlier years, we were injecting air. And then we used to manipulate so that the air will rise to the top. So we manipulate so that the air travels from the lateral ventricles to the third ventricle. You can see that foramen of Monro, and then that's the third ventricle. Going down the aqueduct, you can see on my arrow the aqueduct, the fourth ventricle, and then going out through the foramen of Majandi at Lushka into the cisterna magna. The Majandi was in the middle, the Lushkas were on either side. We had to move the head, so we had to turn the patient quickly from prone to supine, supine to prone, to get the air to move from the lateral ventricle to the aqueduct to the fourth ventricle. And so these are unusual cases where it's the frontal horn which is deformed. There is a shift of the third ventricle. And this is a mydial ventriculogram. So for posterior fossa tumor, sometimes it would be difficult to visualize the fourth ventricle. So we used to inject something similar to lipiodol, which was called myodil, MYODIL. It used to come in 3 ml vials and we used to inject. And in between, myodil was not available, so we used to use Conray. Conray is a dangerous, this was the contrast used for angiography, percutaneous angiography. So this was today what we are using is non-ionic. So this was ionic. And if it leaked into subarachnoid space, it used to cause convulsions and myoclonic jerks if it went into the spine. So it was a dangerous thing. And this is something which you will never see now. This is called pneumoencephalography. This is a contraption which we didn't have. We used to get the patient to sit on a stool and do a lumbar puncture, inject air. The air would climb up into the head and it would go in the reverse manner, meaning from the basal cisterns to the fourth ventricle to the third ventricle to the, across the aqueduct and into the lateral ventricles. So PG was essentially used for communicating hydrocephalus in post TBM patients, but pneumoencephalography is something which is not done anymore. And sometimes you have to turn the patient somersault. This is a myelogram. So if you see the subarachnoid space here is wide, there is a meniscus at the top. So this is suggestive of an intradural extramedullary tumor. If the subarachnoid space is wide, it's an intradural extramedullary. If it is compression of the subarachnoid space from the outside, then it is extradural. So in this case, it's a disc. If it's a tumor also, it will cause similar compressions. So in those days, all neurosurgeons did diagnostic neuroradiology. And at KEM, we decided to switch, not only restrict ourselves to diagnostic, but also do intervention. So we switched over to neurointervention, transfemoral angiography in 76, but I'll come to that in a minute. At that time, there were no special departments for neuroradiology. I told you Dr. Madhavan Pillai started in Chennai in Madras Medical College. So they had one there. Then AIMS in New Delhi, Dr. Golatia was the head of neuroradiology. And at Sri Chitra, Nimhans. And at Bombay Hospital, there was a Adich who had trained in, I think, Norway, and he was doing neuroradiology. In KEM, it was done by radiologists and it was done by us. There was no separate neuroradiologist. The first CT in India was installed at AIMS in 1978, and we started in India in KEM transfemoral angiography in 1976. At AIMS and Sri Chitra, it was started in 1978. All angios were done with the Seldinger needle. There were no introducer sheets, so we used to use a long Teflon guide wire, the regular 150 Teflon guide wire, take it across right up to the arch, then get the French or 6 French. Those days there was no 5 French, 6 French or 7 French catheter in and do the angiogram. And so this is how we had started in 1976 and at AIMS and at Sri Chitra in 78. At AIMS, it was Golatia and N.K. Mishra who were doing the interventions, who were doing the angiography. And in Sri Chitra, it was V.R.K. Rao. Nimhans started doing transfemorals in the 80s. And in fact, they got their first neuro lab in 1985 at Nimhans. And Professor Picard had conducted a workshop at Nimhans at the inauguration. And subsequently, Arya, who was the head of department at Nimhans, and 1 year later, Jaykumar also went to Nancy, France. At the other institutes in India, it gradually started much later. So, as I said, Gulatia and Mishra started in AIMS, V.R.K. Rao in Sri Chitra, and Nimhans late in 1980s, in the late 80s. R.B. Padke, in fact, he attended one of our workshops in KEM and he got stimulated and later went and trained in Sri Chitra and started his own department in SGPGI Lucknow. Khandelwal and Bapurao started at PGI in Chandigarh in the mid-90s. And at Vellore also it was started, but late 90s again. Let me talk a little about the history of our department in KEM. In 1972, Dr. Dastur, who was the founder of neurosurgeon of our department at KEM, he had treated a CCF by attaching a piece of muscle which he had taken from the thigh, and with a string attached to it, he had floated it in, and it had got, by flow, carried into the fistula, and the bruise had disappeared. Dr. Pandya went on a Commonwealth Fellowship to the Queen Square Hospital in London, And there he had seen uh, Lindsay Simon and Bull at work, JD Bull at work. And when he came back, he brought some catheters and guide wires, with which we started angiography at KEM. Mustafa Tayyab Ali, luckily for us, a radiologist, gem of a human being, who was working at Beach Candy at that time in a private hospital, he came and taught us how to do transfemoral angiography. So we didn't know anything about how to do transfemoral angiography. So he came and taught us how to do transfemoral angiography. And initially, Dr. Pandey and I were taught how to do it. So from 76 to 80, we had catheters breaking because we used to reuse, they were all reused catheters. And we used to retrieve them sometimes in this vertebral artery, for instance, we ligated the vertebral artery beyond the catheter because the other vertebral was of a good size. And we used to do embolization for tumors like meningiomas or skull tumors. And there we used to expose the carotid, expose the external carotid, puncture with a needle, and inject gel foam particles to embolize. But during one of these embolization processes, this was a functioning hemodectoma where the BP was very labile. So post embolization, his BP dropped from a high of 200 to almost unrecordable levels. And it was then that we checked his BMA, which was found to be very high. So ever since then, whenever we are embolizing a carotid body tumor or a hemotectoma or a jugulare glomus, we always do the catecholamines because they may be high. And it is better to control them first before we do the procedure, otherwise we can lose the patient. Towards 1980, we were doing an embolization. So at that time, we also started doing embolization for brain AVMs. And we had got silastic spheres, which we used to do a cut down in the carotid in the neck, pass a big tube inside, and float these silastic spheres inside. And we had done about 5 without any problem. On the 6th patient, the balls, the spheres just went up and they stacked along the MCA like a string of pearls. So all the way from M1 to branches, because it was a big artery, all of these had stacked. And we were doing this under local anesthesia. Patient immediately became unconscious, developed hemiplegia. We had abandoned it, took the patient to the OT, opened the Sylvian fissure, opened the MCA, pulled the balls out, but the patient did not survive. So after that, we stopped doing embolization. And Professor Dastoor had always said that we should try and do different things. Each one of us should do different things. So Professor Pandya suggested that I try and do train for neurointervention. But we didn't know where to go or who to approach. So Professor Ramamurthy, who was a friend of our department, he kindly said he would write to Pertuise, who was a neurosurgeon who was doing vascular surgery in La Pitié in Paris. And in fact, he suggested that I go to Professor Picard in Nancy, France, not to his own department, but to Professor Picard. Professor Picard did. So I went to Professor Luc Picard. I wrote to him and he immediately accepted me. And so I went first to Professor Picard in 1980. And subsequently, he took me to Jacques Moret. And the two between them, they really supported neurovascular intervention in India. In fact, I would say that because of their strong support, the standard of neurointervention in India is very high. And both of them were absolute sticklers for technique, for cleanliness. You won't find a speck of blood on the drapes when they were operating. And I'm sure Jacques Moret is a great contributor to the development of neurointervention in India. And most people who have done, amongst at least the senior generation who have done neurointervention, have visited his department or have interacted with him in some way. Ravi Ramakantan was head of radiology at KEM, and he was a brilliant guy. he always came out with solutions whenever there was a problem. So he was also a great support for us whenever we were doing a difficult case. Before 1996, we were only treating certain conditions. We were treating direct post-traumatic carotid cavernous fistula by placing detachable balloons. We were doing parent artery occlusion for giant IC aneurysms, pre-op tumor embolizations, cystoid aneurysms, spinal embolization using particles and sometimes glue, and brain AVM using silastic sphere. This was in the early part. Later we were using glue. And dural AV fistula we were embolizing with lyophilized dura. Okay. So anesthesia is a very important part of neurointervention. We always had an anesthetist with us at KIA. So initially it was under local anesthesia, but later for the intracranial procedures, we used to do them under neuro-left analgesia. So neuro-left analgesia allowed the patient to wake up immediately if he required to check the patient. And it was done with fentanyl and droperidol. So we continued to use fentanyl and droperidol until the 90s. I think the 92, 93 or 94, I'm not very sure when, but droperidol became unavailable. So then after that, we switched to GA. So all subsequent procedures were done under GA. Until 1986, there were no guide catheters and balloons were big. So we could not do embolization for CCF or occlusion of the parent artery from the groin. So we used to do percutaneous puncture in the neck with a long 7F, with a 7F sheath. And the 7F sheath was like a guiding catheter. So through the 7F sheath, we used to float catheters inside and embolize. In 1986, the first guide catheter became available. And again, luckily for us, they were one inside the other, mother-baby type of. So the outer catheter was 9, the inner catheter was 6. If the outer catheter was 8, the inner catheter was 5. And the inner catheter had a shape. So we could torque and we could get into the artery that we wanted. And the balloon, this is the balloon. So if you see, there is a red catheter, there is a black catheter, and there is a white catheter. And there is a ligature. So initially, the balloons that we used had to be tied on with a latex ligature. So we used to make 9 turns and then tie it. But it was very difficult to tie on this red catheter. So we used to tie it on a needle. The balloon is tied on a needle, and then we used to pass the catheter through the needle, clip the catheter on to the balloon onto the needle, onto the catheter, and then take the needle out. So there was no hub. This catheter did not have a hub. We had to mount the hub. We had to prepare and mount the hub on that. And the balloon was on the red. The black was for detaching. So once we were in position, either we used to tug on the red or push the red was longer than the black, or we used to push the black against the balloon and detach it. So our favorite balloon was the number 9, which went through 9 French catheter. And once we had a child, so we could not use a 9 French catheter in a child. So there what we did was use a 5 French catheter, and we introduced it by slitting the sheath. So this is an example, a patient who had bilateral CCF, very high flow, very poor vision, very high ocular pressure. This is right side, this is left side. And you can see the 2 balloons, just with 1 balloon each side on the venous side, with the artery being patent. And 2 days later, you can see the regression of the severe chemosis and proptosis that he had. And so this is very, very rewarding. Patients by evening, most of the times, and very cheap also, because these balloons did not cost much. Those days, the balloons used to cost about 1,000 rupees. So initially, we used to tie a ligature. Later, another company came out. The same company was bought over by Nycomed, which came out with the same balloon, but with a valve inside. So this was a valve which was sitting inside. So later, Bolt, the other company which made balloons and catheters, also came out with similar detachable balloons. So I told you that about CCF and parent artery occlusion. We used silastic spheres until about 87. And then we had this liquid embolic material called isobutyl 2 cyanoacrylate. So this isobutyl 2 cyanoacrylate was injected through silastic tubing. And later this was withdrawn because it was thought to be carcinogenic. The Magic family of catheters became available in 1989. Until we had the Magic catheters, get into position to inject glue, it used to take us an hour. And the aim at that time was not to inject into the nidus. The aim was to occlude the artery. So we used to inject 66% glue in those days. Later, of course, after 94, 92 or 93, I think, we changed and we started going for the nidus. So this is the catheter that we used to use in the beginning before the Magic came. This was a syringe or two syringes, one inside the other, with nail at either end. This was a tubing which was coiled up in the chamber which was filled with saline. We had to make sure that the entire system was free of air. There was no air in the system. There was a balloon at the tip of the microcatheter. So this was the tubing, 0.4 by 0.7 tubing, as I said here, and 0.3 by 0.8 tubing. And we used to add a balloon at the tip. So we used to inflate the balloon gently so that with blood flow, it would go up where we wanted it to go. And we used to inject into the side arm of the Y. This is the Y that we had in those days. So we used to inject 10 ml of saline into this, so the saline would go and push this, unwind this catheter into the artery. So it was very crude. So this is a child that I had done in those days. We didn't have DSA. This was a non-subtracted. It was a pica feeder with a large AVM, and my catheter got stuck somewhere in the pica, and I couldn't inject anything. I couldn't push, I couldn't pull. The catheter got stuck there. So after much debate, what to do, we decided that we would inject something and come out and cut the catheter in the groin. But when we cut the catheter, to my horror, I found that the catheter had recoiled into the PCA on both sides, into the superior cerebellar on both sides, and come back, and the lower end was at L1. You will be surprised. This patient did very well, no problem at all. Subsequently, she came again, and we embolized her 3 times more thereafter. Now, why I had the courage to do this is because I had gone for observation or as an observer to Gerard de Brun. Gerard de Brun was one of the pioneers of neurointervention, French guy who was in London, Ontario, in Canada. And he was working with Charles Drake, who was one of the pioneers of vascular surgery in Canada. Most of the neurosurgeons will know Charles Drake. So there I had seen he had a similar problem, and there they did an angiogram from the other side, and then they just cut the catheter and left it in the groin. So therefore, I had the courage to do that, and I had many patients with catheters in their head, and without any complication at all. So we used to also embolize juxtacranial intracranial tumors, and this was usually done with gel foam because this was essentially preoperative. So we used to cut the gel foam into small bits and float it in contrast. So diluted contrast so that you could see where it is going. And as soon as there was reflux, we would stop the embolization. So this is just an example of a large meningioma, massive edema, patient put on steroids. This is the angiogram, and then we go into meningeal and we embolize with gel foam. And at this time, we were also using PVA particles. So initially we were using gel foam. Later we were using PVA particles, and you can see the tumor is completely devascularized, vascularized. So when this patient was operated, the tumor literally got sucked away, literally got sucked away. And in such patients, if you do histology, you will find the PVA particles inside the tumor bed. So I said, 1996 was a watershed area for all of us in the world, neurointervention. Why? Because up to that point, we were only treating giant extracranial aneurysms, So I didn't mention, but we treated some intracranial aneurysms using tungsten coils. So these were coils which were introduced by Bolt, but these were just pushable coils. So you just had to push them. You couldn't retrieve them. You couldn't reposition them. Once it left the catheter, you had to just deploy it. So I had done one neurolevy fistula, one pile fistula, and three aneurysms with this. But all of these coils used to get reabsorbed. So after 1 year, if you did an X-ray, there was no coil. It was gone. So naturally, we had stopped using those. So after 1996, GDC became available. When they first introduced GDC, they said that we have to be proctored. We have to learn how to use it. So all of us were sent for training. So Uday Limay and N.K. Mishra from Delhi were sent to Perth, Australia. Santosh Joseph was then at Sri Chitra. Harsh Rastogi was my colleague in Apollo. And myself, we went to Oxford. Shailesh Gaikwad from AIMS and Dhawan Modi from Mumbai. And the fellow radiologist, somehow I can't remember his name, he went to Seoul, Korea. And initially, we were only treating large aneurysms, and gradually we started doing remodeling with, after Jacques Moret showed us how to use them, we started treating smaller aneurysms with balloon, sometimes with a single balloon, sometimes with kissing balloons. Then the stent was introduced by an Indian. His name is Arani Bose. So the first two stents ever to be used were the Neuroform, which Arani had designed and developed in America, but Uday Limay used one and I used the other in Apollo Delhi, and we had done very well with this open cell neuroform stent. So the neuroform stent again is a pushable stent, not retrievable. Once it is out of the catheter, it has to be deployed. So we used the first one then. And then, of course, now there are many types of stents, closed cell design, open cell design, etc. Then the flow diverters came, and now the latest on the block is flow disruptor, which is the WebCon and the contour. But I must tell you that over the years, all these devices have got better and better. The device itself, the construction of the device, the delivery wire, the detachment system, all of these, you take a coil up there, you position it. But how do you make sure that the coil stays? So they made it a complex coil, so that there is no reabsorption. They added a coating to it. Hydrogel was added so that it will swell up and occupy more space in the aneurysm. So these are all modifications which have evolved. So all of these devices keep evolving. What is good today, 6 months later may not be as good. There might be something new which is better. So it is always in a state of flux as far as devices are concerned. Guiding catheters. I told you the first guiding catheter was available in 1986. And we had to stay in the common carotid artery. By 1996, we had 99, maybe 2000, we had got guiding catheters which you could take up into the internal carotid up to the skull base. But you do not take those tonsillar loops if there was a loop. Now we have got guiding catheters which can traverse even very tight loops. If you are careful, you don't cause dissection. You can go all the way up into the M1, into the basilar. So, but you have to be, of course, be very careful. So all devices are getting better and better. So here are some examples of the types of balloons. So we have the non-compliant balloon, which is typically used for an ICA, internal carotid supraclinoid, or petrous, or cavernous ICA, or basilar artery. And we have the compliant balloon, where it takes the shape of an adjacent branch also. So at the bifurcation, so the first balloons were the hyperglide and the hypoform, but now we have many different companies having such similar or more compliant balloons. And sometimes, now here typically we have gone from the ICA to the A1 or ICA to branches of MCA, but we can also come from PCOM across A1 to go and position a balloon across the basilar top or the ICA top to be able to coil aneurysm at the ICA top. Then the stents, I told you that we use the first neuroform, but now there are a whole lot of stents. So the stent is placed across, and either we go through the interstices of the stent like it is in B, or we jail the catheter and we deploy the stent. Sometimes at the bifurcation, a Y stenting is required. So Y stenting is done in two ways. Either the stent goes through the interstices of the other stent, or the second stent is positioned so perfectly that it is like a Y. And in this instance, stent on one side. So today we have a device, what is the name? Merlin, I think, where you position it, you ratchet up, it opens out partially, deploy your coils, and then unratchet and take it out. So that is a temporary stenting also possible today. What about brain ABMs? I told you we injected silastic balls. Then we started injecting liquid embolics, and we used the magic group of catheters. So initially there were no wires, so we just had to advance and manipulate and turn and shape the catheter so that we could get into the branches. But in the early 2000s, we got the Mirage and the hybrid wire. The Mirage and the hybrid 007 and 008 really changed our life. From taking 2 hours to access the fistula, the ABM, now we are in position in about 10 minutes. Initially, we were using glue, but with glue, at least I was never very happy. We would never get a very complete embolization. Onyx was later introduced, and again, just as for GDC, we were sent for training in the use of Onyx to Ankara in Turkey, to Saruhan Sekirje, and Santosh, Harsh Rastogi, Shaji Marar, who is at Jaslok in Mumbai, and myself, we went to Ankara for training in the use of Onyx. Uday and the others went somewhere else, I don't know where, but we had all gone to Onyx. And since 2006, we have been using Onyx for embolization of brain AVM and dural fistula. And with the Magic is not compatible with Onyx. This is one thing that one must remember. One can only use glue with Onyx. So we started using the marathon catheter, which would go, or ultra flow catheter, which would go into the nidus. We would inject the Onyx. But if it was a long injection, if we were to pull that catheter out past all those bends, there was a high risk of rupture of the artery or a catheter breaking. So we used to cut it in the groin and leave it there. So because we didn't want to do that, the companies, as I said, keep innovating. So they came out with this Sonic and Apollo catheter, which have a detachable microtip. So the distal 2 centimeters or so is left behind. The rest of the catheter comes out easily. So this is how we were doing for some years. And then René Chapot described his pressure cooker technique. In the pressure cooker technique, when you're injecting Onyx, there is a reflux. So in the pressure cooker technique, you block the parent artery, the artery which is to be embolized, so that there is no reflux. And now the Onyx only goes forwards. So this pressure cooker technique is now accepted across the world. The venous route was still taboo until Hungarians first described it. Two Hungarian neurosurgeons described it in 2012. It took another 5 years before it was generally accepted. And now in many centers, the venous route is the accepted route, but not as the first route. The first route is still the arterial route. To finish off, because now we have understood that just getting the nidus is not enough. You have to get the vein. If you don't get the vein, the AVM is going to come back. So after we having got the nidus, one has to get the vein. So today it is accepted that you do as much as you can from the arterial side. And if there's a good vein giving you an access, then you go in from the venous side. And different compartments have different draining veins. So today, on the newer machines, you can get a beautiful uh, roadmap of what is happening. Then you go on to carotids. After 1996, up before 1996, the stents which were used were all balloon mounted stents, which were not very good. The guidance stent used to deform and used to fracture. After 1996, the self expanding stents came. Initially, they were stiff, they were big, they were not meant for carotid, and they were over the wire. So you had to have a 300 centimeter wire. And the ID was a 35 wire. Today we use a 014 wire. So in 2002, the rapid exchange system came, and then there were open cell and closed cell designs. And recently we've got the C-guard, which has a membrane inside, and the Caspar, which is a multi-layered carotid stent. Caspar has not been used in India because they've still not introduced it in India. One reason is also it is very expensive and it may be more thrombogenic. I did not mention hardware. See, to keep up with all this technology, how if you are to get into a small perforator and go distally, navigate distally into it, you have to be able to see well. You cannot work blind. So initially, when we started, we had an Lima Schoenander skull table, and gradually these dedicated neuro labs came. In the first neuro labs, subtraction was either photographic. So you had to, the first film was only the skull, the second, third, fourth were with contrast. So you subtracted the first, so you exposed it, what was black became white. Now what you got as the angiogram is black, so white and black subtract, skull is gone, you only see the artery. So this was called photographic subtraction. Later it became electronic subtraction. So initially in the 80s, what came was subtraction, but not real time. So you couldn't see it on the table. The subtraction was done as a post-processing thing. So you could only see it after 2 or 3 hours. Gradually, it became real time. The subtraction became real time. Then roadmap was added. So in roadmap, what was black becomes white. Then when you're moving your catheter, you can see against a white background. So real-time subtraction roadmap, magnification. Initially, we could only work with one focus. Gradually, images got better and better. And now there are two types of magnification. One is the photogenic, where the tube itself, the pinhole changes, and the other where it is an electronic magnification. So both are today available on neurolabs. Initially, we had only monoplane, then came biplane. Biplane again has been a real eye opener because you can do in one plane when you're injecting onyx, you're deploying calls, you may think you are perfect. You look at the other plane, you realize everything is all haywire. So biplane is has increased the safety, reduced the amount of contrast, reduced the amount of time, but most important, it has improved safety. 3D angio, 3D RA angio rotation angiography was great because small, especially these blister aneurysms and things like that, which could be missed. And now we have got 4D RA, 4D rotation angiography, where it is in time. So you rotate it, but you can also follow the contrast going up, and then you can still rotate it. It is wonderful. 4D. So today, for an AVM, if you have a 4D angio, it is very, very useful to look at the. So just to show you some examples, this is the Lima Schoenander machine. So this was a C-arm. So this is actually the Schoenander. And we used to have this box. And this box had 3 trays. So this box was actually originally designed by Mahadevan Pillai. And we were still using these boxes until the late 80s and early 90s. And we had very good fluoroscopy. So the intervention was done on fluoroscopy, but the radiography was done using this changer. So this was a changer, and we had to pull out the trays one after the other. And we had to time it so that we get the right arterial, capillary, and venous phases. Then the newer thing is the CT on the neuro lab. And even this quality of CT has got better and better. So not only can you see the hemorrhage, but today you can even do the stroke protocol. And I'm told that in Ahmedabad, there is a neurologist whose cath lab in his hospital, he does not have a CT, but he does have this CT on the neuro lab. His patient goes straight to the neuro lab and the imaging is done there, and then the patient is taken for intervention. Vaso CT, this is something which is again very useful. After you have deployed a stent, one is never sure whether the apposition of the stent to the arterial wall is accurate. But with the Vaso CT and the Dyna CT, it is very useful. And not only that, Vaso CT, Dyna CT is also very useful for angiogram, for DSA, for brain EVM, for analyzing brain EVM. What is the feeder, internal aneurysm, the draining veins, the different compartments. They are beautifully seen on Vaso and Dyna CT. And finally, the newest thing on the block is CT and MR fusion. So CT and MR can be imported into the neurolab. The images can be fused, and the angiography, when it is done, can be. So in a patient whose creatinine is very high and you don't want to dialyze, people have done. They got the CD from the original CT or MR, which has been done either in the same hospital or elsewhere. Not done a preoperative angiogram. They've gone straight for the embolization. So, and of course, there is CT CO2 angiography, but that is not useful in India. We don't, I mean, not for neuro work. Today, what we are doing mostly is for acute ischemic stroke. So before 2015, we used to do thrombolysis by direct injection of urokinase or RTPA into the thrombus. We used to go with the microcatheter inside but it used to take an hour for our process to be done. But today, with these thrombectomy devices, the aspiration and the stent retriever, we are able to open the artery in 15 minutes, most of the times. Of course, there are difficult cases where you may take 2 hours and 3 hours and 4 hours. But the average time taken to recanalize an occluded artery today is 15 to 20 minutes from groin. So, in fact, in all over the world today, the largest number of interventions are done for acute ischemic stroke. And I hope that this will go on and we'll do many more ischemic strokes. So today, what are the indications? Acute ischemic stroke, aneurysms and their complications like spasm, AVM and spinal cord embolizations, AV fistulas, angioplasty stenting for intracranial, extracranial atherosclerosis, embolization of tumors, intracranial and juxtacranial and spinal, thrombolysis for intravenous thrombosis. We see a lot of, in India, we see a lot of cortical vein and superior sinus thrombosis. So thrombolysis for that, and venous stenting for idiopathic intracranial hypertension. I would be feeling if I didn't talk about training. Training is a very important part of neurointervention. So Professor V.R.K. Rao started a 1-year post-diploma certification course at Sri Chitra in 1985. And in 1989, he started DM in neuroradiology. In fact, he was one of the first to have beds allotted for neurointervention, separate from neurology and neurosurgery. So his students have been trained in clinical neurology also. And he did live workshops in 1991 and 2001. And Professor V.R.K. Rao was a great inspiration for generations of neuroradiologists at Sri Chitra. At KEM, I was instrumental in doing the training. So Uday Limai worked with us for 18 months in 85, 86. Harsh Sogi worked with me in Indraprastha for several years. Anil Karapurkar trained with me in Bombay Hospital in 2003 and 4. And many doctors have since been trained at Bombay Hospital and Beach Candy Hospital by me. And now Anand also is. So at AIMS, let me talk about DM neuroradiology, which was started at Trivandrum first. And now it is also being conducted the DM neuroradiology courses being done also at AIMS, NIMHANS, PGI Chandigarh, and SRMC Chennai. And training in the, so in these institutions, the training is imparted in diagnostic and interventional neuroradiology. It's a 3-year DM course, just like DM neurology and MCH neurosurgery. DM neuroradiology is a 3-year course. At KEM, Uday, Siddharth, and Manish were colleagues, and later they had started taking trainees from 2001. And the trainees were all full time, and they came for 2 years. And the Maharashtra University of Health Sciences started a diploma in training in interventional neuroradiology, but it was meant only for radiologists. And it was started in 2008, and it is still continuing. Uday has also conducted these Circle of Willis teaching programs. These were very good teaching programs where from basic to latest technology, everything was covered. And he did this for a good 10 years from 2006 to 2016. And the WFITN, World Federation of Interventional and Therapeutic Neuroradiology, have also got a training program called the Planet. So Uday conducted one of the WFITN training Planet programs in Mumbai some years ago. Professor Matthew Cherian at Coimbatore Medical College Hospital started training radiologists for the first decade of 2000, and he has trained several radiologists since then. And right now, he is conducting a training diploma course or a degree course of the MGR University in Chennai. Karapurkar, one of the alumni from Sri Chitra, he is also conducting a training program at NNC Kolkata for several years. Shakir, one of our neurology colleagues, trained under Valavanis at Zurich, and then he came back to India, started at Delhi, and he has trained a whole lot of neurologists in various aspects of intervention, acute stroke, ischemic, as well as hemorrhagic. Anand Alurkar has been training doctors at Pune, and his is also a full-time 2-year training program. Vikram Huded, who was trained by Uday in KEM, is also taking at Narayan Hrudayalaya, is taking students since long. And Gigi has been training neurologists for acute stroke at Cochin. This is a new course which has been started by Rahul Kumar at Patna. And I think this is a very good course. He covers everything from basic neurovascular anatomy to techniques. And it's all very solid, very good information, very practical information. I hope he continues to have these teaching courses. So I had a slide of Santosh. Joseph, what happened to the slide of Santosh? I seem to have missed the slide of Santosh Joseph. So Santosh Joseph started live. Oh no, that is I think coming later. Sorry. So this is about training, and so now we have these fellowships which were funded by Medtronic. There were 7 for STNI and 7 for SNVI. So the SNVI fellowships have been discontinued now, but for STNI, I believe they still continue. The DNB board started FNB in 2019, and 4 centers have been approved, and the first batch has already cleared the FNB examination. So in India, 6 new students are taken every year, and right now we have 4 with us who have come. So it's a 2-year training program. There's an entrance exam, there is a didactic training program, and there is an exit exam at the end of 2 years. So this is the FNB. The WFITN, the World Federation of Interventional Therapeutic Neuroradiology, Dr. Mishra and I were members of the training committee for many years. We were members of the technical and standards committee and of the ethics committee. And I was one of the founder members of the AFIT and the Asian Australasian Federation of Interventional Therapeutic Radiology. And I was the president in 2006. So this was when the inaugural meeting was held in 1991 in Beijing, and we had a meeting in Goa. The complication is a very important part of neurointervention, and Uday has been conducting this meeting in Goa since 2003. So the first one was held by us in Delhi. The next one was in Lonavala by Uday. And then from 2000 onwards, 2004 onwards, every year in Goa, except during this lockdown period, we've had a meeting on complications. It's a very good meeting. And I personally think that we learn more from complications. And it is always better to learn from others' complications than to have our own complications. So this is a picture of the Goa meeting. That's the tall guy here is Uday. Next to him is me, Professor Picard, and Professor More at one of the Goa complications meeting. You can see we are in a relaxed atmosphere. We are in our shorts, and this is how this Goa meeting is conducted. In Mumbai, after I came back to Mumbai, we had monthly meetings every month, regularly, without fail, from 2002 to 2017. And these were very good meetings. And for some reason, they were discontinued in 2017, but they have again been revived by Nishant, Aditya, and they are being held once a month again on a regular basis. So this is the latest meeting that we had at HN Hospital. So that's Nishant who's conducting the meeting, and that's Uday at the back. This is Dr. Rajiv, who's at the Naval Hospital, and the others are from Kokila Bay. Manish was missing because he had to go somewhere. International conferences, I told you we had this. So workshops, we had multiple workshops, and I think workshops, especially the live workshops, are very informative. So in 1982, we had this workshop at KEM, the first workshop, which was only for KEM colleagues, which Professor Picard had done. Then in 1985, we had a live audio-visual workshop. First time in the country, we had an audio-visual live workshop where you could interact with the speakers and during the procedure. And 89 again, we had with Professor More and Picard. And then 4 years when I was at Apollo Delhi, Professor, I was there from 96 to 2002. We had every year a live workshop, and Professor More and Picard used to come for it. 2002, after I've come back to Mumbai, I've not organized any live workshop. 2002, Professor Limay organized workshop at KEM with Professor More. So this is during the 1985 workshop, Professor Picard with a patient. And this is during the 1997 workshop, we are felicitating Professor More, and this is you can see the discussion that is going on. And this was another very good thing which Santosh had done from 2003 to 2018. Every year, except for I think 1 year when it had been cancelled, Dr. Santosh Joseph organized live workshops every year. And Renish Chapeau, who's a wizard, like Jacques Moret, came for most of these workshops, all these workshops in fact. And we've all learned a lot from him over the years. Various things, what to do, what not to do, everything. And I think this workshop has really been extremely useful for neurointerventionists, not only in India, but he used to get people coming from Sri Lanka, from Bangladesh. So it's been Nepal also, I think, has been very good. So that's Professor Renish Chapeau. You can see the big smile on his face, and he has been very helpful for us. In fact, Dr. Rakesh Singh, my present colleague, and one of our students, Mukund Vidhate, also spent some time with him in his department at SN, Krupa Krankenhaus. Live workshops are also done at AIMS, at Sri Chitra, and Vipul Gupta has done my live workshops at Max Hospital, Delhi, and later at Medanta and our Artemis. And these again are very useful workshops, widely attended and very instructive. Unfortunately, there are too many societies in India of intervention. So the STNI, the Society for Therapeutic and Neurovascular Interventions, is Society of Radiologists. SNVI is Society of Neurovascular Intervention. is a society for clinicians. ISNR was formed in 1996 and it is a society for neuroradiology. Originally, it was from the beginning, it has been both diagnostic and therapeutic. And ISVIR is actually a society for the peripheral guys, but they also do carotids. So some part of ISVIR discusses carotids. And now they want to venture into intracranial circulation also. So ISVIR colleagues. So if I may be permitted to take another few minutes, can I?
Yeah. Yes.
For our younger colleagues, I have some advice. You can see I have white hair, so I think I have the right to give you some advice. Our first priority should be patient care. Everything else is secondary. So patient care should be first. But we should also teach. So if we have new guys and teach not only the doctors, but teach our technicians, our nurses, because they have no idea about what neurointervention is. They know nothing about, often they know nothing about the clinical neurology either. So I think it is very important that we teach. Research is something that we don't do much of, and this is all across India. We should do clinical research. We should do research in basic sciences. Again, we don't do anything there. And we should publish. Publish is something which Indians don't do. And except for some people here and there, like my former colleague Atul Goel, Atul churns out a paper every 2 weeks. Perhaps not so much, but we should publish. And this is, we are all guilty of it, including myself. So we must publish whatever. Make time for yourself and family. There is so much burnout today. People get burnt out or they have incapacitating diseases. So take care of yourself. Make time for family, take holidays, travel. And outside our professional life, develop a hobby. Let it be anything. Let it be painting, music, games, sport, reading, wildlife. Do something. And we must attend professional meetings to update ourselves. You may think you know everything, but there is always something which you do not know. So always attend professional meetings and listen to what is being said and done. You may learn something at any stage of life. And I like to end with my philosophy of my father, which I have followed all my life. So these are some aphorisms of his. One-liners. Be confident but not proud. If you're not confident, you cannot do anything. You cannot even move one pen from here to there. But if you become proud, there will be a fall. Do your duty without expectation of any return. You have to do your duty. Don't you help somebody. Don't expect that he will help you again. You should help him because that is the right thing to do. So do your duty without any expectation of return at all levels. As a man, as a doctor, as a surgeon, as a family man, brother, sister, whatever. But everywhere you must do your duty. Of course, you must do it with love, but without expectation of any return. Hope for the best, but prepare for the worst. So, if you have a complication, you hope for the best. You hope that the patient will come out, but you must be prepared for the worst, including the patient dying. So, explain this to the patient beforehand, but always hope for the best. Think autocratically, behave democratically. So, whatever others may say, let them say whatever they want. You don't do it. You do, you think for yourself, and you think, you do what you think is right. So, this is exactly the reverse of what is common in society. In society, everyone, it's more like a mob thinking. It should not be mob thinking. Everyone should think for oneself. Always look at positives. The glass is always half full. And I think this is the most important. Everything has a price. There is nothing without price. Whatever, everything has a price. And to my mind, money is the cheapest. So once you have paid the money for anything, you don't have any obligation, you don't have any worries that you have to repay, how you will repay, nothing. So money is the cheapest price. This is my principle, and all these I have been following, and I have been trying to inculcate in my students also as far as possible. So thank you very much for your attention. I have gone well over an hour, so do excuse me for having overstepped. Thank you.